In this video, we're going to cover antipsychotic medications. I'm going to give you the most important things you need to know about each medication. We're also going to cover how to monitor patients while on these medicines and how to use long-acting injectables. Welcome to Treatment Tuesday. Here's the list of all the medications we're going to cover today, including the second-generation antipsychotics, a few first-generation antipsychotics, all the long-acting injectables, because those are super important to know because they're so helpful for patients. Which antipsychotics don't cause any weight gain, or very little. We're also going to group them by mechanisms a bit, and I'm going to give you the monitoring parameters. What do you need to monitor when you're prescribing these medications? I'm not covering every single second-generation antipsychotic. However, these are basically all the second-generation antipsychotics that you'll need to know. And for the first-generation antipsychotics, we really don't use those that often. So if you know haloperidol, fluphenazine, and Loxapine, you're gonna be good to go. Let's start off with Aripiprazole, also known as Abilify, the brand name. So the dose for schizophrenia and mania starts at 10 to 15 milligrams per day, and the max is 30 milligrams per day. That's a very high dose to start someone at, 10 milligrams per day. They'll probably have a little bit of side effects with that. Normally, akathisia, which is a really intense restless feeling inside. People will be pacing around or might feel like their skin's crawling. Now for major depressive disorder, that's MDD, autism, and Tourette's, you can start at 2 to 5 milligrams per day. That's a lot more usual dosing. You can increase by 5 milligrams every single week to 15 milligrams max daily. You don't want to increase more frequently than every week because the half-life of aripiprazole is so long. So what's the MOA, the mechanism of action? The good news is it has many of the same properties as Brexpiprazole and Cariprazine. Namely, it's a D2, so a dopamine 2 partial agonist. It blocks 5-HT2A. Remember, 5-HT just means serotonin. It's a serotonin 1A partial agonist. It also blocks 5-HT2C and 5-HT7. It has actions at D3, didn't specify what that was. And it also blocks alpha-1 adrenergic, so sometimes can cause hypotension. What are the benefits? Well, it doesn't cause any gynecomastia, so it doesn't cause any breast tissue development in men. It actually decreases prolactin levels. There's a long-acting injectable available. It doesn't cause any weight gain, or very little. It doesn't have any sedation, so it doesn't make you sleepy. It can actually be activating, which is good. Sometimes we want that. And it has a really long half-life of 75 hours. What are the side effects? No weight gain, no sedation. It can cause dizziness, trouble sleeping, akathisia, and activation can cause you to feel really activated. Akathisia, you can use propranolol, a benzodiazepine, that's a benzo, or mirtazapine to treat that. Akathisia is an intense feeling of restlessness or feeling like your skin's crawling. You'll see patients pacing around, unable to relax. That's akathisia. It's drug-induced. You can also get nausea or vomiting. Some of the less common ones are constipation, headache, asthenia, which is just weakness, orthostatic hypotension, so people's blood pressure can go down when they stand up too fast. And that's usually during the initial dosing, so when you're just starting the medication. It can also cause TD, tardive dyskinesia. You're going to see that a lot today, TD. And tardive dyskinesia happens when there's decreased dopamine for too long in the nigrostriatal pathway in the brain, and you can get these abnormal movements of the trunk, the extremities, the arms, the legs. You can also get abnormal movements of the face, the mouth, the tongue. You can get lip puckering, and the tongue can come in and out. Those are things to look out for. Now, as for the metabolism, it's a 2D6 and a 3A4 substrate. These substrates are what the liver metabolizes in the drug. Some tips are, it has a super high affinity for the D2 receptor, so sometimes in psychiatry, 2 different antipsychotics can be used. It's not frequently done, but sometimes it can be done. And it's important to remember that aripiprazole has a really high affinity for the D2 receptor. So if you're giving aripiprazole, and if you're also giving risperidone at the same time, or some other antipsychotic medication, it might be making the other antipsychotic, the second one, less effective. And so when you take away the aripiprazole or you decrease the dose, it might actually allow the risperidone to work better. There's a long-acting injectable called Aristada, and remember, we're going to go over all the long-acting injectables in depth individually later on. But this long-acting injectable, Aristada, can be started within 1 day by also giving the long-acting injectable Aristada with this Aristada Initio. This Aristada Initio is the one you give once, and you give that together with a 30 milligram tablet. Again, we'll go over that all later in a lot more depth. Next one is Brexpiprazole, also known as Rexulti. For schizophrenia, you want to start at 1 milligram daily for days 1 through 4, and then you increase to 2 milligrams daily for days 5 through 7, and then you increase to 4 milligrams, you double it on day 8. For major depressive disorder, MDD, you want to start at 0.1 to 1 milligrams daily, increase weekly, up to 1 milligram once daily, and then up to 2 milligrams once daily. Similar mechanism, D2 partial agonist, 5-HT2-1 partial agonist, 5-HT2A blocker. Remember we talked about the serotonin hypothesis for schizophrenia in the psychotic disorders video, so that's where we're seeing that again. It's also alpha-1B blocker. This decreases arousal, agitation, and makes akathisia less likely. It's an alpha-2C blocker, which can help with antidepressant benefits. And it blocks 5-HT7 and has actions at D3. It didn't really specify what kind of actions it has at D3. What are some of the benefits? Well, it has less akathisia than Abilify, so that's good. It might improve cognitive impairment in schizophrenia, and it has a long half-life of 81 hours, a little bit longer than Abilify. Some of the side effects, it's not unusual to have weight gain. Sedation is not unusual, it can make you a little sleepy, so more so than Abilify. It can cause akathisia, restlessness, anxiety, it can cause headache, and of course tardive dyskinesia. The metabolism is the same as Abilify, it's a 3A4 and 2D6 substrate. It has a lower affinity for D2 than Abilify, but it has a much higher affinity for 5-HT1A and 5-HT2A, which gives it the anxiolytic effect. Brexpiprazole does have some anxiolytic effects. Sometimes we add that on as an adjunct for a major depressive disorder, in addition to an serotonin reuptake inhibitor, or sometimes for an anxiety disorder, it can also be added as well. Cariprazine, also known as Vraylar. How do you start this medication? Well, for schizophrenia and mania, you start at 1.5 milligrams daily, you increase to 3 milligrams daily on day 2, and you can increase further by 1.5 to 3 milligram increments. That's very aggressive. Now, probably in the inpatient setting, you'll do that in the hospital. Most of the time in the outpatient, you use this dosing scheme. For bipolar depression and major depressive disorder, you start at 1.5 milligrams daily, you increase to 3 milligrams daily in 2 weeks. That's a more usual dosing scheme. The mechanism of action is the same as Abilify and Rexulti, at least for the top ones. Some of them are the same as Abilify and Rexulti, so it's a D2 partial agonist, stabilizes dopamine. It's a 5-HT1A partial agonist, again it stabilizes dopamine. 5-HT2A blocker increases dopamine in certain parts of the brain. And that's how it decreases extrapyramidal symptoms versus the conventional antipsychotics. It's also a D3 partial agonist, stabilizes dopamine. It prefers to bind to D3 over D2 at low doses. It improves negative symptoms in schizophrenia. It has a 5-fold selectivity for D3 over D2. So this is an interesting one, and one of the only ones that improves negative symptoms in schizophrenia. It's also a 5-HT2B blocker. The benefits, well, it's a D3 partial agonist. It's approved in Europe for negative symptoms of schizophrenia. That's good to know. Sometimes other countries are a little bit ahead, or maybe they just have different studies that they have acted on, but that's very reassuring to use that in schizophrenia for negative symptoms since it's approved in Europe. It's good for mixed major depressive disorder or bipolar states. Some of the side effects, well, side effects can take weeks to show up due to the long half-life of the active metabolite. Really, really long half-life. Weight gain is unusual, it shouldn't happen. Sedation, not unusual, it could happen. Akathisia, extrapyramidal symptoms, which are Parkinson's, drug-induced Parkinsonism, akathisia, and dystonia, where you get muscle cramping, muscles stuck in one position. You can also get restlessness and tardive dyskinesia. Remember, these extrapyramidal symptoms are more acute. They happen a bit faster. The Parkinson's, the akathisia, the dystonia, and the tardive dyskinesia, well, tardive just means later on. So that's why it takes usually months and months until the tardive dyskinesia develops. Metabolism, it's only a 3A4 substrate. It has the longest half-life of any antipsychotic, and it causes more extrapyramidal symptoms than Abilify and Rexulti, also more nausea. Now, Lumateperone, also known as Caplyta, how do you start it? Well, you start it at 42 milligrams daily, and that's it. It's very easy to start. There's no titration. That can be a plus or a negative if someone has side effects. What's the mechanism? Well, it's a D2 blocker, postsynaptically. 5-HT2A blocker, that's normal, most antipsychotics are. Presynaptic D2 partial agonist, that's interesting. So it has a partial agonist in there. D1 dependent activation of AMPA receptors, causes mTOR pathway activation, which causes antidepressant effects. This is quite unique to this one. I didn't see this mechanism of action with any other antipsychotic that we're going to review. It has affinity for serotonin reuptake pump, so might boost serotonin, it doesn't really say, it's unclear. What are the benefits? Well, you only need 1 dose. It doesn't cause drug-induced Parkinsonism or akathisia nearly as likely, and no weight gain, so that's a plus. What are the side effects? Weight gain? No. Unusual. Sedation? Yep. Dry mouth, nausea, tardive dyskinesia. It's a 3A4 and 1A2 substrate. Tips? Well, there's no generic. That's unfortunate, so it can be expensive. Let's go on to Lurasidone. Lurasidone, very often used. For schizophrenia, you want to start at 40 milligrams daily with a 350 milligram meal. You gotta have it with a meal always, otherwise it won't absorb. You want to increase to 40 milligrams every greater than 3 days. Bipolar depression, you start at 40 milligrams, again with a meal, increase by 20 milligrams every 2 days. And for major depressive disorder, you start at 20 milligrams and you increase usually every week. Mania, it doesn't say, you're on your own there. There's no guidance. What's the mechanism? Well, it blocks dopamine, D2. It blocks 5-HT2A, blocks 5-HT7, alpha-2A and 2C. And it's a partial agonist at 5-HT1A. It also blocks alpha-1 adrenergic receptors. Most of these do block the alpha-1 adrenergic receptor. A few don't though. And that just means it can cause orthostatic hypotension. What are some of the benefits? It can actually cause weight loss. It improves hemoglobin A1C, which is the blood sugar, over a 3-month period. It doesn't affect lipids, and there's no QTC prolongation per stalls. What are the side effects? You can get short-term weight gain. That's common. It's important to tell patients this. You can gain 1 to 2 pounds in 6 weeks. But the long term, patients actually lose 1.5 pounds on average at the 52-week mark. So it's like, if you gain a pound or 2 in 6 weeks, don't worry about it. Like, this medication actually makes you lose weight in the long term. Sedation, yeah, it can make you sleepy. However, in clinical practice, I hardly ever notice that. Very infrequently do patients tell me it makes them sleepy. It can cause akathisia, nausea, and tardive dyskinesia. It has a moderate risk of hyperprolactinemia. It's also dose dependent. The higher the dose, the more you can get that, so high prolactin. It's metabolized by 3A4, and you're not supposed to take it if you have a strong 3A4 inhibitor or inducer. You can take it at night to avoid akathisia. That's a good tip. It's pro-cognitive due to 5 blocking, so it doesn't cause any confusion or anything like that. It's good for treatment-resistant patients who might need a combination of 2 second-generation antipsychotics or 1 second-generation antipsychotic and 1 conventional like Iloperidone. Could also do one depot shot, and meaning a long-acting injectable, and 1 by mouth, which is PO. Quetiapine. So how do you start this one? Well, let's go over the ones we'll use more often. So Quetiapine. So for schizophrenia, the immediate release, you want to start at 25 milligrams twice daily. You want to increase by 25 to 50 milligrams daily in 2 divided doses on days 2 and 3. Then by day 4, be at the target dose of 300 to 400 milligrams daily. That's pretty aggressive. Mania, we're probably going to be pretty aggressive too. Yeah, start at 50 to 100 twice daily. Increase by 100 milligrams total daily until at 400 daily on day 4. So similar to what the schizophrenia one was. I'm not sure why they changed it up there and made it slightly different. You're still at 400 on day 4, but that's what they say. And for generalized anxiety disorder, GAD, you want to start at 25 to 50 milligrams daily, increase weekly. It doesn't say how much to increase weekly, so we're going to increase it by 25 to 50 milligrams. We want to be pretty gentle there. We don't need to increase too rapidly. For major depressive disorder, you start at 50 milligrams daily. You do that for 2 days. Then you increase to 150 daily on day 3. What's the mechanism? Well, it blocks D2, it blocks 5-HT2A, and it's also a norepinephrine reuptake inhibitor. It blocks 5-HT2C and 5-HT7. It's a partial agonist at 5-HT1A. It also blocks H1, which is the histamine, alpha-1 adrenergic, and muscarinic cholinergic receptors. What are the benefits? It's sedating, so it's good for people who have trouble sleeping. It's also good for Parkinson's disease psychosis. There's no motor side effects or hyperprolactinemia, so it can be good if people have a tardive dyskinesia. You can usually give them this one. Clozapine's another one. So what are the side effects? Weight gain, common. Sedation, problematic. Well, sometimes we want that for sleep. It has an increased risk of diabetes, trouble with the lipids, dizziness. It can also cause dry mouth, constipation, dyspepsia, abdominal pain, tachycardia, orthostatic hypotension, and tardive dyskinesia. It's a 3A4 substrate. What's interesting is if you increase the dose very fast, like in mania or in psychosis, it actually causes less sleepiness. Schizophrenia and mania do better with higher doses, but bipolar disorder does better with lower doses, interestingly. Lower dose meaning less than 300 milligrams daily. and sometimes as little as 25 milligrams daily. Ziprasidone, also known as Geodon. They give this one in the emergency department sometimes as an injection usually. In our case, we're going to be giving it by mouth. So how do you start this? Well, for schizophrenia, you want to start at 20 to 60 milligrams twice daily. Now it says 40 milligrams twice daily or 60 milligrams twice daily are better tolerated. There's less activation, which is interesting. Normally you want to start at a lower dose because it's tolerated better. Here it says doing a higher dose is actually better tolerated with ziprasidone. This is the only one that I've seen that has this. The lower dosing is more activating because of strong 5-HT2C antagonism. That's the reason. For bipolar disorder, you want to start at 40 milligrams twice daily, increase to 60 milligrams or 80 milligrams twice daily on day 2. Pretty aggressive. That's for mania, most likely. Up to date says for major depressive disorder, off-label, you want to start at 20 milligrams twice daily with food, increase to 40 milligrams, increase by 40 milligrams weekly. The mechanism of action, it blocks D2. It's a serotonin 2A blocker and 5-HT2C blocker. It has interactions with 5-HT1A, 5-HT1D, and 5-HT7. Didn't really say, didn't specify, so we're going to ignore those. It also blocks alpha-1 adrenergic receptors. It doesn't cause any weight gain, and there's no interactions. Those are benefits. It doesn't cause any weight gain, and most of the time it doesn't cause any interactions, even though, as we'll see here, the metabolism is 3A4 substrate. Most of the time it doesn't cause any problems. Side effects, weight gain is unusual, sedation, not unusual, could happen. Activation at very low to low doses, which is very interesting to know. We gotta remember that one. It can cause dizziness, it can cause DI, Parkinsonism, so drug-induced Parkinsonism. It can cause dystonia at high doses, nausea, dry mouth, asthenia, which is weakness. It can cause a skin rash, orthostatic hypotension, or tardive dyskinesia, metabolism 3A4 substrate. What are the tips? Well, it has the shortest half-life of all second-generation antipsychotics, 2.5 hours. You gotta be cautious with the QTC prolongation. This is one of those that causes that a lot. So you gotta ask about the family history. You gotta ask if they've ever had QTC prolongation, if they've ever had any arrhythmias or any heart problems. For schizophrenia and bipolar disorder, you need to be above 120 milligrams daily for this to usually work. Usually dosed twice daily, but many patients do well with a once daily dosing at bedtime. So that's nice to remember. If it's very difficult for a patient to get the twice daily dosing, you could consider just giving it all at night. See how they do. Now, Risperidone. How do you dose this? Major depressive disorder, low dose, 0.25 to 0.5 milligrams daily. You want to increase by 0.25 to 1 milligram every 3 to 7 days, up to 3 milligrams max. Now, for mania, the doses, and schizophrenia, the doses are going to be higher. For mania, you start at 1 to 3 milligrams daily in 1 to 2 divided doses. Increase by 1 milligram daily until at 4 to 6 milligrams daily range. For schizophrenia, you start at 1 to 2 milligrams daily. In 1 to 2 divided doses, increase by 1 to 2 milligrams every day to get this 2 to 6 milligram daily range. What's the mechanism? It blocks D2 and 5-HT2A, it blocks 5-HT7, it also blocks alpha-1 adrenergic. What are the benefits? Well, there's a liquid, there's an orally disintegrating tablet, and there's a long-acting injectable. It's also good for explosive behavior, and so is aripiprazole. What are the side effects? It can cause weight gain, sedation, sleepiness. It can cause increased risk of diabetes and dyslipidemia, so the lipids are all out of whack. It has a dose-dependent drug-induced Parkinsonism and akathisia risks. It definitely causes hyperprolactinemia. Prolactin goes up with this, Risperidone. Same thing as Paliperidone. Dizziness, insomnia, anxiety, sedation, fatigue, headache, cause nausea, constipation, abdominal pain, dry mouth, dyspepsia, tachycardia, sexual dysfunction. The sexual dysfunction is from the hyperprolactinemia, and tardive dyskinesia. It's metabolized by 2D6. It's just given once daily, so it's easier for patients. You can give it twice daily, but just give it once. Patients do well on the once daily usually. The risk of drug-induced Parkinsonism is increased above 6 milligrams daily, so normally you want to stay below that. Hyperprolactinemia in women with low estrogen may accelerate osteoporosis. That's a good one to remember if you're treating women that are postmenopausal and don't have the estrogen. Now, paliperidone, how do you start this? Well, you start at 6 milligram daily in the morning, increase by 3 milligrams daily every 5 days. You don't need to titrate up. You don't need to start lower. It's used off-label for bipolar and major depressive disorder as an adjunct. It agrees. What's the mechanism? Well, it's the same as risperidone. It blocks D2, 5-HT2A, 5-HT7, and alpha-1 adrenergic. You don't need to titrate. That's a plus. And no metabolite interactions. So nice. Paliperidone. What are the side effects? Can cause weight gain, sedation, dose-dependent drug-induced Parkinsonism, hyperprolactinemia, increased risk of diabetes and dyslipidemia, tachycardia, hypersalivation, so you're salivating too much, orthostatic hypotension, because it blocks alpha-1 adrenergic receptors. All the ones that block alpha-1 adrenergic receptors, which is most of them, can cause orthostatic hypotension. And there's tardive dyskinesia. Metabolism, no interactions. Does it cause QTc prolongation? It's a little unclear. Different sources say otherwise. Stalls says yes, so I'm going to believe them. Up to Date disagrees. They say Risperidone is 2+ for QTc prolongation and Paliperidone is 1+. We're just going to go with Stalls on this and say Paliperidone, you got to be a bit more careful with the QTc prolongation. Paliperidone is the active metabolite of risperidone. And this is just a theme for hyperprolactinemia. If the prolactin goes too high, you got to remember in women with low estrogen, postmenopausal, it can accelerate osteoporosis, so they get those weak bones. So you got to be really careful with that. Iloperidone, also known as Fanapt. This is a newer one. You want to start at 1 milligram twice daily, then increase by 2 milligrams twice daily to the recommended dose range of 6 to 12 milligrams twice daily. Max, you want to do 32 milligrams total daily. It's used off-label for mania, bipolar depression, and major depressive disorder. What's the mechanism? It blocks T2, it blocks 5-HT2A, and it blocks alpha-1 adrenergic. Pretty simple mechanism, not too much else. What are the benefits? No drug-induced Parkinsonism or akathisia, so that's nice. No extrapyramidal symptoms. What are the side effects? It causes weight gain, sedation, orthostatic hypotension, yes, increased risk of diabetes and dyslipidemia, dry mouth, nasal congestion, tachycardia, tardive dyskinesia. It's 2D6 and 3A4 substrate. It prolongs the QTc, so we got to be careful with that. Geodon in this one, those are two big ones to remember. Apparently paliperidone as well. A 4-week depot preparation is in clinical testing. That's exciting. We might be able to add a new one to the video in a little bit. Vansarin, this one is completely different from the rest of them. If there's one you remember that stands out, this is the one that stands out. How do you dose this? You start at 32 milligrams daily, no titration. You just start at 32 and you go from there. It's a blocker / inverse agonist at 5-HT2A. Some say blocker and inverse agonist are the same thing. They're a little bit different. We're just gonna call it an inverse agonist at 5-HT2A. It's also an inverse agonist at 5-HT2C. What are the benefits? Well, it doesn't worsen Parkinson's disease at all. There's no weight gain or sedation. And you don't need to change the dose of anti-Parkinsonism dopaminergic therapy. So when someone's on levodopa or another dopamine agonist, you don't need to change any of that. The neurologist doesn't need to worry about anything if you're on pimavanserin for delusions or hallucinations or psychotic features. What are the side effects? Weight gain? No. Sedation? No. It can cause peripheral edema, confusion, nausea. It's metabolized by 3A4 and 3A5 substrate. That's the only 3A5 we're going to see on this list. It's a bit unusual. What are the tips? Well, it prolongs the QTc. Look out for that one. Same as iloperidone and geodon. It shows improvement in negative symptoms in schizophrenia when augmenting atypical antipsychotics. This has been reported, but it's now in phase 3 trials for negative symptoms in schizophrenia. So there's not much we can do about negative symptoms. Remember Cariprazine, that can help negative symptoms. Europe says so. So this might be another one. We might have 2 now. Okay, we got Asenapine here. So there's a few different formulations here. There's sublingual, it goes under the tongue, and there's transdermal, it goes on the skin. So for the sublingual, you don't want to eat or drink for 10 minutes after taking it, because that can affect absorption. For schizophrenia, you start at 5 milligrams twice daily. The max is 10 milligrams twice daily. For mania, if you want to start just that drug, you start at 10 milligrams twice daily. If you're adding it on to something else, you want to start at 5 milligrams twice daily, then increase to 10 milligrams twice daily the next day. It's used off-label for bipolar depression and major depressive disorder. This transdermal one is very interesting. It's a bit different. You can apply the Sequado, which is the brand transdermal system, every 24 hours to either the hip, the abdomen, upper arm, or the lower back area. You want to start at 3.8 milligrams every 24 hours, and then in 1 week, increase to 5.7 milligrams for every 24 hours, or 7.6 milligrams for every 24 hours. But what's the dosing equivalent from the sublingual to the transdermal patch? Well, the Sequado 3.8 milligram for every 24 hours is equal to 5 milligrams twice daily sublingual, and the 7.6 for every 24-hour patch is equal to 10 milligrams twice daily sublingual. What's the mechanism? Well, it blocks D2 and 5-HT2A, 5-HT2C, 5-HT7, and alpha-2. It's a partial agonist at 5-HT1A, and it also blocks alpha-1 adrenergic receptors. What are the benefits? Well, it has a sublingual, and it's a very rapid onset, and it can also be used as needed if there's a patient who has lots of aggression. What are the side effects? Weight gain? Yeah, it could happen. Sedation happens a lot. Dizziness, akathisia, increased risk of diabetes mellitus, and dyslipidemia. Oral hypoesthesia, so you can get decreased sensation, maybe some numbness there. Orthostatic hypotension, drug-induced Parkinsonism, and tardive dyskinesia. What is it metabolized by? Well, it's a 1A2 substrate, and it also inhibits 2D6. For the tips, heat increases the rate and extent of absorption of the transdermal patch. So you gotta make sure not to get that patch hot. No saunas, no hot tubs, or anything like that. Showering's fine, but it doesn't say whether you should soak in it or do a bath or go for a swim, so that's unknown. Olanzapine, also known as Zyprexa. Well, there's a tablet and there's also an ODT, an orally disintegrating tablet. You want to start at 5 to 10 milligrams once daily, increase by 5 milligrams every week, max of 20 milligrams daily. There's also 2 other formulations. There's an olanzapine and fluoxetine formulation, which is fluoxetine is a serotonin reuptake inhibitor, and there's an olanzapine samidorphan combination as well, which causes less weight gain. That's why that one's good. So for the olanzapine fluoxetine, you start at 6 milligrams / 25 milligrams daily in the evening. There's a max dose. For the olanzapine samidorphan, it's also known as Lybalvi, it's a brand name. You start at 10 milligrams of each nightly. And the max is 20 milligrams of olanzapine and 10 milligrams of samidorphan. The samidorphan stays constant. Could also do 5 milligrams of olanzapine and 10 milligrams of samidorphan for schizophrenia, or 15 milligrams of olanzapine and 10 milligrams of samidorphan for mania. What's the mechanism? Well, for olanzapine, it's a D2 blocker. It blocks 5-HT2A, blocks 5-HT2C, also blocks histamine 1, blocks alpha 1, and blocks muscarinic cholinergic receptors. Now, fluoxetine is a serotonin reuptake inhibitor, and it also blocks 5-HT2C. Samidorphan's a little bit different. It blocks mu opioid receptors, and it's a partial agonist at kappa and delta opioid receptors. What are the benefits? Well, it's the second best working antipsychotic, so it works the best for psychosis, only second to clozapine. And it's in the low weight gain category when combined with samidorphan. I did see this. I would be a little skeptical of that. I would probably put it in the moderate weight category just because olanzapine causes so much weight gain. It's hard to imagine just adding in samidorphan puts it in the low weight gain category altogether. But that definitely helps. If you're going to do one, don't do olanzapine, just do the Lybalvi to decrease any kind of weight gain. Side effects, weight gain, problematic, is a problem. Sedation, yep, causes a lot of it. Increased risk of diabetes and dyslipidemia because it causes so much weight gain. It can cause dizziness, weakness, dry mouth, constipation, dyslipidemia, peripheral edema, joint pain, back pain, chest pain, extremity pain, abnormal gait, ecchymosis, so bruising, tachycardia, orthostatic hypotension, and tardive dyskinesia. It also causes a rare rash on exposure to sunlight. So you might see that, but it's rare, so probably not. What's it metabolized by? Well, olanzapine is a 1A2 and a 2D6 substrate. Remember, cigarette smoke decreases olanzapine levels. Why? Because tobacco is a 1A2 inducer. Inducer, D for decreases the plasma levels, right? So 1A2 inducer, but nicotine gum and nicotine patches don't do anything to the 1A2 substrate, so you're fine there. What about samidorphan? Well, it's a 3A4 substrate. And fluoxetine, 2C9 substrate. It also inhibits 2D6, 3A4, and 2C19. So since it's a 2D6 inhibitor, it might make the olanzapine slightly stronger since olanzapine is a 2D6 substrate. Inhibitor H for high plasma levels, also known as blood levels. So what are the tips? Well, women metabolize 1A2 substrates slowly. So women might have up to double the blood level of men taking the same dose. So that's important to remember with these 1A2 substrates. Olanzapine and clozapine is also a 1A2 substrate. There we go, clozapine. So what's the dose? How do we do this? Well, before you start, you gotta ask about neutropenia. Have you ever had neutropenia? Which means neutrophils of less than 1,500 microliters. Or have you ever had granulocytosis, which is a severe form of neutropenia, where they've had less than 100 microliters of neutrophils? Have they ever had heart disease, metabolic syndrome, or seizures? Now, how do you start this in the outpatient setting? We don't care so much about the hospital setting. We're gonna be doing this outpatient in the office. So how do we do this? Well, you wanna start at 12.5 to 25 milligrams nightly, just a once daily. You also wanna add docusate sodium, 250 milligrams in all patients. It prevents constipation. And you want to add metformin for weight gain prevention. Just add these. People gain weight on Clozapine. You just want to add that. Don't even wait for the weight gain. Just add those on. You want to increase by 25 milligrams weekly until at 100 milligrams daily. Once you're at 100 milligrams daily, you increase by 50 milligrams weekly. If you have a pre-Clozapine antipsychotic, someone's taking Abilify or something else, pre-Clozapine, you start tapering this medicine once Clozapine is in the 100 to 200 milligram range, not before. You want to decrease the pre-Clozapine antipsychotic by 1/4 dose every week once you're at that range. So for example, if a patient is taking 20 milligrams of Abilify, you decrease by 5 milligrams every week until no longer taking. So what's the mechanism? Well, it blocks D2 and it blocks 5-HT2A. It has interactions with 5-HT2C and 5-HT1A. Not too helpful, it didn't really say what interactions it has. It also blocks alpha-1, muscarinic cholinergic receptors, and H1 receptors. What are the benefits? Well, it just works the best. It's the most powerful. It has anti-suicidal properties, just like lithium does. Not many medicines do that. It's good to use if a patient has tardive dyskinesia or Parkinson's disease. It doesn't cause extrapyramidal side effects. 1/3 of patients get no benefit really. 1/3 do pretty good, and 1/3 get great benefits. So that's important to remember. So what do you need to monitor with this? This one's different. Clozapine is the one that we're gonna go over the monitoring here. Later, we're gonna go over monitoring for all antipsychotics. But here, we're gonna go over the monitoring for Clozapine specifically because it's so specific. Pre-treatment labs, what do you need to get before you even start? You wanna get a complete blood count with differential. You wanna focus on the absolute neutrophil count. Remember those neutropenia and agranulocytosis numbers? That's what you're looking for. You wanna get a fasting glucose. You wanna get lipids. You wanna get hemoglobin A1C. You wanna get inflammatory markers, CRP. You want to get CPK, you want to get troponin, look at the heart. We're looking for myocarditis, right? We want to monitor this. We want to have a baseline. You get an EKG, you look at the heart. You get an HCG qualitative for all women of reproductive age that looks for pregnancy. You want to get vital signs, a BMI, and a waist circumference. We want to make sure they don't gain too much weight. What's the ongoing blood monitoring? It's intensive. You need a weekly CBC for the first 6 months. Then you need a CBC every 2 weeks for months 6 through 12. And after a year of being on it, you gotta get a CBC every month. Less than 500 neutrophils per microliter is bad, yes. It's not agranulocytosis, but it's definitely neutropenia. You also wanna get a weekly CK, CRP, and troponin I. It doesn't say for how long. So most likely for the first couple of months. What are you looking for? You're looking for myocarditis. You gotta catch that. What are the side effects? Well, there's 5 black box warnings. Agranulocytosis, the risk is about 1%. Orthostatic hypotension, people get dizzy when they stand up too fast. Dose-dependent risk of seizures, about 3%. You can get myocarditis, and you have a risk of stroke in patients with dementia. The risk of stroke in patients with dementia, that's with every antipsychotic. What are the other side effects? Well, you get a benign fever in 20% of patients. Very interesting with Clozapine. So if someone gets a benign fever, it's nothing too much to worry about, but they do need to be evaluated for it. Metabolic syndrome, tachycardia, cyalorrhea, so they're just drooling too much, constipation, and OCD symptoms. What's it metabolized by? Well, primarily 1A2. That's mostly the biggest one to remember. And then also, you can also remember 2D6 and 3A4 if you want. It also inhibits 2D6. You need to have the REMS, the risk evaluation and mitigation strategy. You gotta go online and you gotta sign up for that to prescribe this. Not just everyone can prescribe this. Well, that's all the second generation antipsychotics. Well, that was quick. So let's go over the first generation antipsychotics. Again, we don't prescribe these much because they cause a lot of extrapyramidal side effects, drug-induced Parkinsonism, dystonia, akathisia. We just don't prescribe this much. It can also cause tardive dyskinesia a lot more commonly because they block D2 so potently, and they don't block 5-HT2A. So it doesn't help increase dopamine in certain parts of the brain. But anyway, let's go over haloperidol, fluphenazine, and Loxapine, okay? So how would you start haloperidol if you're gonna start it? Well, for schizophrenia, 2 to 10 milligrams daily is where you start. The max is 30 milligrams daily. Just note, StalMed says the max is 100 milligrams daily. That's why it's good to look at multiple sources. 100 milligrams daily is a really high dose. I would go with the 30 milligram max daily dose. For mania, you want to start at 2 to 15 milligrams daily, increase by 5 milligrams every 2 days. Again, max to 30. Go with up to date on this. Don't go up to 100. It's too much. What's the mechanism? Well, it blocks D2. That's about it. It also blocks the alpha-1 adrenergic receptors. You can get orthostatic hypotension, of course. What are the benefits? It has a 4-week depot shot. It might be helpful to top off an atypical antipsychotic in aggressive patients. It's also cheap. It's been around for a long time. What are the side effects? Well, it can cause weight gain. It's not unusual. It can cause sedation. It's not unusual. It can cause neuroleptic-induced deficit syndrome, which just means it worsens negative and cognitive symptoms. Cause akathisia, drug-induced Parkinsonism, galactorrhea, which means discharge from the nipples, and amenorrhea, so the period can just stop in women. It can cause dizziness, dry mouth, constipation, blurred vision, urinary retention, increased sweating, hypotension, hypertension, so it can cause low or high. It can cause tardive dyskinesia, tardive dystonia, and a rare tachycardia. It's metabolized by 2D6 and 3A4. It also inhibits 2D6 and 3A4. Higher doses might cause or worsen negative symptoms in schizophrenia. It's important to remember. If anti-Parkinson's drugs are used, continue them for a few weeks after stopping haloperidol. Okay? It can get patients out of a mania, but it can put them straight into a depression, unfortunately. So, fluphenazine. You want to start at 0.5 to 10 milligrams in divided doses and max of 40 milligrams daily. So I'd probably give this twice daily. It blocks D2. It also blocks muscarinic, cholinergic, histamine, and alpha-1 adrenergic receptors. It again can be used to top up an atypical antipsychotic for aggressive behavior, same as haloperidol, and it has a depot shot, but you need to do it every 2 weeks, at least initially, and then sometimes you can do it a bit further out, like a 4-week. Side effects, yeah, it can cause weight gain sometimes, sedation sometimes. These side effects are very similar to haloperidol, so we're not going to go over those. The 2D6 substrate and the tips. Fluphenazine tabs, 2.5, 5 milligrams, and 10 milligrams have tartrazine, which can cause allergic reactions, especially in patients sensitive to aspirin. So that's an important one to remember. Maybe ask people if they have an allergy to aspirin. For the depot shot, blood levels tend to increase over time, so check blood levels every once in a while. You might need to lower the dose. Also, avoid the sunlight with fluphenazine. It seems to make the skin more sensitive to sunlight. Loxapine. So this is the last first-generation antipsychotic that you could potentially use. We're not going to go over any other ones. No one really uses them. So how do you start this? Well, you want to start at 10 milligrams twice daily. You want to increase over to 7 to 10 days to 30 to 50 milligrams twice daily. The max is 125 milligrams twice daily. So that's a big dose. 250 total daily. What does it do? It blocks D2. It also blocks 5-HT2A. Even though it's a first-generation antipsychotic, it's a classical antipsychotic, it blocks 5-HT2A, so it's kind of more like a second-generation antipsychotic. It also blocks muscarinic, cholinergic, histamine, and alpha-1 adrenergic receptors. What are the benefits? Well, you can top up an atypical for as-needed use, 25 to 50 milligrams by mouth or intramuscular. Kind of similar to what the other ones said. No weight gain with this one. It's good to give together with Clozapine in partial responders. Interesting to remember. Weight gain? No. Sedation? Yes, common. Especially with higher doses, which means greater than 50 milligrams total daily. It can cause neuroleptic-induced deficit syndrome, which is the negative symptoms you get with these first generations. Akathisia, drug-induced Parkinsonism. It causes galactorrhea and amenorrhea because it blocks dopamine in the tuberoinfundibular pathway, and that blocks dopamine in the pituitary, and that's how you get the high prolactin. It can also cause hypotension, dry mouth, constipation, blurred vision, urinary retention, tardive dyskinesia, rare tachycardia. No real metabolism interaction that are clinically significant, so that's really nice. It's 5-HT2A blocking. Works at the lowest doses. So once you get into higher doses, it just doesn't work as well. That's probably why it's not a second-generation antipsychotic classification. So the low doses are 5 to 30 milligrams total daily. And remember, this medication can go up to 250. It gets overwhelmed at the high doses, so it basically works as a second-generation antipsychotic, but only at the low doses. Many patients do well at the 20 to 60 milligrams per day, just taking Loxapine. So you might be a little cautious to increase this really strong up to 250. And some patients do well on once nightly dosing, which is interesting. Kind of like Geodon, it's dosed twice daily, but sometimes you can do it once daily. So here's the long-acting injectables. There's Aripiprazole, which has a few different ones there. There's Paliperidone, a few different ones. Risperidone, a few different ones. Olanzapine. And then there's the first generation. haloperidol, fluphenazine. Let's go over them. So, aripiprazole, Maintena. Gotta know this one. 300 to 400 milligrams every 4 weeks. You gotta give 2 weeks of bi-mouth overlap. The equivalency there, 300 milligrams of Maintena is 15 milligrams of bi-mouth Abilify, and you see the 400 milligrams is 20. So let's move right on. Asymptophy. So aripiprazole, same as Maintena, but this one you gotta give every 2 weeks, not every month. Can you go from oral to asymptophy? You can give 960 milligram injection together with a 7-day bi-mouth Abilify, and you just decrease it to 720 if the patient has side effects. It doesn't give any guidance on bi-mouth equivalent dosing, and I'd be cautious to give someone a 2-month supply of medication if they've never had the Maintena, which is a 4-week. I would do the 4-week first. It didn't say to do that. I would do it. Aristata. This one has variable dosing, anywhere from 4 to 8 weeks. And that's dosing based. So equivalent dosing of Aristata, 10 milligrams is 441, 15 is all of those, and 20 milligrams or higher is 884. So how do you give it? Well, what you do is you give the 675 milligram dose of Initio in one shoulder, right? You also give them a bi-mouth 30 milligram tablet. This is the loading dose. This is how you do it. Of course, you want to use different injection sites. So what are some of the tips? Well, Aristata is more painful than Maintena, but Maintena you can only do for 4 weeks. You can't potentially do it up to 2 months. So that's the benefit of this. And you have more flexibility in the dosing with this Aristata versus the asymptophy. Plasma levels of these aripiprazole long-acting injectables increase over time, so you want to get periodic plasma levels to make sure they aren't increasing too much over time. Check blood levels the morning of the day they're getting their next injection. That's important. So Paliperidone long-acting injectables. Well, there's a few. Let's start with Sustenna, because this is the monthly injectable. Just like Maintena is Abilify, Invega Sustenna is the monthly Paliperidone one. So if you're going from oral to Paliperidone palmitate, which is the Sustenna, you want to do a loading dose. You give 234 milligrams on day 1, and then you give 158 milligrams on day 8, both in the deltoid. Then on day 36, you give the first maintenance and use the oral equivalence chart. So whatever they're taking, let's say they're taking 6 milligrams of Paliperidone right now, do the loading dose as it says there, 234 on day 1, 156 on day 8, and then give them the long-acting injectable 117 milligrams on day 36, and then keep giving it to them every month after that. But you need to give at least 2 oral doses before giving injections. This is the same for all long-acting injectables. Always give at least 2 oral doses. Make sure they tolerate them well. Make sure they don't have any bad side effects or any allergic reaction. Now, long-acting injectable to Invega Sustenna, monthly injection. How do you do that? How do you change from something else like Maintena to the Sustenna? Well, you just replace the other one that you were going to give injection, and you just give this one instead. It's real easy. There's the equivalence chart. Now, Invega Trinza. This one's a game changer. It's every 3 months, which is a long time. Very good. How do you go from bi-mouth Paliperidone to Trinza? You don't. You got to give the Sustenna first, and you got to do that for a long time. You need to do the Invega Sustenna for 4 months first before giving this Trinza. How do you do it? Well, when month 5 is coming up and it's time for another Sustenna, just don't give it and give the Trinza instead. What's the Sustenna to Trinza equivalent dosing? Well, if you're taking 117 like we talked about, which is 6 milligrams of Paliperidone, then when it's time to give the Trinza, you give 410 milligrams. Real easy. There's this new one called Invega Halfiera. You give it every 6 months. This is going to be so helpful for a lot of people. So how do you go from oral to Invega Halfiera? You don't. You got to have at least 4 months of the Paliperidone Sustenna, or at least 1 injection of the 3-month of Trinza before you can move on to this one. It just makes sense. How do you go from the Sustenna to Halfiera? Well, just replace the Sustenna when it's on month 5 with the Halfiera. And the only equivalent dosing you can do is you have to go at least at 156 milligrams, and then you give 1,092, or 234 and you give 560. If you want to go from the Trinza to the Hafyera, there's the dosing as well. Now we move on to Risperidone microspheres. Consta is the first one we'll go over. How do you go from oral to Consta? Well, oral coverage is required for 3 to 4 weeks. Long time. You got to give this bi-mouth Risperidone for 3 to 4 weeks until the Consta kicks in. 2 milligrams of oral Risperidone equals 25 milligrams of long-acting injectable every 2 weeks. You got to give this every 2 weeks. Max dose is 1 milligram vial. A 1 milligram vial is 50 milligrams. So 50 milligrams is the max every 2 weeks. You want to wait every 4 weeks to increase the dose actually. You don't want to increase every 2 weeks. There's another Risperidone microsphere called Rykindo. How do you go oral to Rykindo? Oral coverage is required for 7 days. This is the only difference. Everything else is exactly the same. The dosing is the same. And you also give it every 2 weeks. I wouldn't even give the Consta. Maybe it's cheaper. Maybe that's why people give it. The Rykindo sounds better. You only have to give by mouth for 7 days. Sounds way simpler for the patient. Now we're talking about Risperidone subcutaneous. So it's not in the muscle, it's subcutaneous instead. There's one called Uzedy. How do you go oral to Uzedy? No loading or oral supplementation. You don't need it because it's so fast. It absorbs so fast, which is awesome. So there's the dose forms. You want to give it once monthly or once every 2 months by subcutaneous injection, which is nice. So you could give this every 8 weeks if you wanted to. There's the dosing scheme, the oral Risperidone to the Uzedy once monthly, and then the Uzedy every 2 months. So that's a nice one. There's also a Risperidone subcutaneous one called Perseris. How do you go oral to Perseris? Again, no loading or oral supplementation, which is awesome. You start at 90 milligrams, which equals 3 milligrams of by mouth, or you do 120, which equals 4 milligrams. Doesn't have that much flexibility in the dosing. You either do 3 milligrams equivalent or 4 milligrams equivalent. Give once monthly by subcutaneous injection in the abdomen. What's the difference between Uzedy and Perseris? Uzedy has 1 to 2 month options. Uzedy has higher dose options. 5 milligrams per equivalent. Uzedy wins. I would just use Uzedy. Olanzapine, wait, we're gonna learn about it, but it's really no good. So olanzapine, pamoate, you give it every 2 to 4 weeks. You need to monitor for 3 hours post-injection monitoring due to a rare risk of post-injection delirium from vascular breach. So you accidentally inject the olanzapine into the veins and they get this delirium. So you gotta watch them for 3 hours. That's why most people aren't gonna take this. There's the dosing equivalent. We're not even gonna go over it because most people won't prescribe this. Haloperidol. So how do you go from oral haloperidol to haloperidol decanoate? Well, you gotta give a loading dose. You gotta give 20 times the by-mouth dose for the first month to load. You divide it into 2 weekly injections, and then you give the maintenance dose every 4 weeks. So here's how you do it. So the patient is taking 15 milligrams of haloperidol by mouth. It's a usual dose, totally possible, right? We go times 20. So 15 times 20 is 300. That would be the loading dose. But remember, you can only give a max of 100 for the first injection. So what you would do is you would give 100 for the first injection, and then in 3 to 7 days, if they don't have any extrapyramidal side effects, they don't have any drug-induced Parkinsonism, they don't have any dystonia, they don't have any really bad akathisia, you give them the best. You give them the other 200 in 3 to 7 days, no problem. The FDA max is 450, which is equivalent to 30 to 45 milligrams by mouth daily. That's a lot. Remember, we want to go max 300 by mouth daily for haloperidol. It carries a significant risk of tardive dyskinesia, so we don't want that. And how we can decrease that is we can try not to exceed 200 milligrams of the long-acting injectable monthly. That'll be equivalent to 20 milligrams haloperidol by mouth. Of course, you want to check the serum levels and make sure they're not super low for some reason. You also want to consider a 25% dose decrease about every 3 months because the haloperidol decanoate tends to just accumulate and stay in the body. So you want to check blood levels and you want to be decreasing this most likely. Patients can't tolerate above 300 milligrams doses at a time. Even when they're on maintenance, you can't do it. So you want to split that dose. If someone is taking 400, this is just an example, 400 milligrams, you would want to split it into 200 milligrams at different times. Basically give it every 2 weeks instead of every 4 weeks. There's also sesame oil in this that can cause a local irritation site. Flufenazine has the same sesame oil. Here's flufenazine. How do you go from oral to flufenazine decanoate? You want to give the by-mouth dose at half the dose for at least 2 weeks. So to look for the equivalent dosing, let's say someone is taking 10 milligrams daily. The long-acting injectable would be 12.5 milligrams every 2 to 3 weeks. And so what you would do is, since you want to give the half of the by mouth dose for at least 2 weeks, you would give the injection of the 12.5 milligrams, and you would also give the patient 5 milligrams of by mouth flufenazine for 2 weeks to bridge them. You can use the equivalent dosing chart that we had, or you can also just go 1 milligram of oral daily is approximately 1.25 of long-acting injectable every 3 weeks. Again, I like the slide better, the dosing equivalent slide better, because sometimes you can dose it further out. You don't have to dose it every 3 weeks, and so that's a bit better. It gets to the peak max concentration fast, only in 1.5 days. Very fast. The injectable gets to the peak concentration very fast. So patients can get extrapyramidal symptoms and akathisia, which is an extrapyramidal symptom, within the first 48 hours. So you gotta watch for this. You gotta give the injection, and then you gotta watch. Dosing maintenance schedule, you can get 12.5 up to 100 milligrams every 2 weeks, max is 100 milligrams daily. Increased by 12.5 milligram injections if dosed above 50 milligram is needed. So you wanna go slow if you're above 50 milligrams. Oh, here's another example. So if the patient is taking 7 milligrams of flufenazine daily, that's 8.75 milligrams injection of the long-acting injectable. We could just round this down to 6.25 and use the chart. So we would, let's go to the chart. See, we round down 6.25, we wanna give it every 2 weeks. So what are the no weight gain antipsychotics, or the ones that cause very little weight gain? Well, we got Abilify, which is Aripiprazole, Brexpiprazole, Cariprazine, Lumateperone, Lurasidone, which remember, causes 1.5 pounds loss over 52 weeks. They gain a little 1 to 2 pounds initially in 6 weeks, but then they lose ultimately. Ziprasidone, Vansarin, all these are excellent. Now, here's something we can do to monitor weight gain and to catch it before it gets too bad and unmanageable. If the patient gains more than 5% of their body weight in 1 month, we gotta prescribe metformin. Where do we wanna get? We wanna get metformin ER in the 1 to 2 gram daily range. So this is how you do it. You start metformin ER at 500 milligrams once daily with the biggest meal. You increase by 500 milligrams weekly until you're at 1 gram twice daily. You want to get the 1 gram twice daily. It works best there. You want to get to the max dose if the patient can tolerate it. You want to check BMI. You want to check a complete metabolic panel, a lipid profile, hemoglobin A1C, and a B12 at baseline. The B12, you want to check that then every year, and you want to tell them to take a B vitamin for the B12 because metformin can make you lose B12. So what are the mechanisms here? Well, Aripiprazole, Brexpiprazole, and Cariprazine all have similar mechanism in that they're all a D2 partial agonist. They are partial agonist at 5-HT1A, and they block 5-HT2A. The only inverse agonist at 5-HT2A is Vansarin, and it's the only one that doesn't block or partially block D2. And all these other ones are D2 and 5-HT2A blocking. We got Lumateperone, Lurasidone, Quetiapine, Ziprasidone, Risperidone, Paliperidone, Iloperidone, Asenapine, Olanzapine, Clozapine, and Loxapine. Remember, Loxapine first-generation antipsychotic, but it also blocks 5-HT2A. And then the D2 blockers, haloperidol and flufenazine. So how do we monitor people when they're on the second generation or first generation, any antipsychotic? How do we monitor them? Well, you want to get a baseline BMI. You want to get a blood pressure. You want to get a FBG, fasting blood glucose. You get that in the CMP. I would just get a CMP. Hemoglobin A1C, and you want to get a lipid panel. And what do we need to check every visit? Well, we want to check for extrapyramidal symptoms and tardive dyskinesia at every visit. We do 2 weekly follow-ups after starting an antipsychotic, or increasing the dose to check for extrapyramidal symptoms. Now, at baseline and once yearly, you want to get a BMI, a blood pressure, fasting glucose, hemoglobin A1C, and a lipid panel. That was just a summary up top. We're going a bit more in depth here. At every visit, when making med changes, and for the first 6 months, you want to check BMI. It's really important to make sure they don't gain too much weight. Then check BMI at least every 3 months. So check BMI every visit. Normally, you want to do a visit every 3 months. When making medication changes or starting a new one, you want to check everything except BMI, right? So you want to check the fasting blood glucose, the blood pressure, the hemoglobin A1C, the lipid panel, every 4 months. Why except BMI? Because BMI, you just check it every visit. Okay, so in summary, we're wrapping things up here. Remember what to monitor for labs and the questions to ask. You want to ask for extrapyramidal symptoms. You want to ask for tardive dyskinesia. Watch out for weight gain. Make sure they don't gain too much weight. Know the most commonly used meds. You need to know Abilify, Lurasidone, Quetiapine, Brexpiprazole, Cariprazine, and Risperidone. Those are the most used ones. If you know those, you'll be in good shape. You want to know the long-acting injectables for Aripiprazole and Paliperidone. These are the only ones you need to know to do well. If you know the other ones, great, but these are the most important ones. For Aripiprazole, you want to know Maintena, which is the monthly one, and you want to know Aristata, which is every 1 to 2 months. For Paliperidone, you need to know Invega Sustenna, which is monthly, and you need to know the Invega Trinza, which is every 3 months. If you know those, you'll be in good shape. Here's the sources. I hope you enjoyed the video, and let me know in the comments below if there's anything new you'd like me to cover, or if you have any questions or comments. Thanks for watching.